two. So I think your topic for the week is skin disorders, and I can imagine a few reasons why adrenal disorders got lumped into that, although it's not completely parallel. But I'll touch on a couple of things. So there's a whole lot of things I could focus on with adrenal gland issues, but I chose to focus on adrenal gland hypofunction. I could do a whole nother lecture on hyperfunction if you guys are wanting me to, but today we're going to talk about hypofunction. So if you sat in one of my lectures before, I think it's really important to understand and at least review normal physiology before you can fully understand pathology. And so we'll talk about just adrenal gland structure and function, and then some of the physiology behind the renin-angiotensin-aldosterone axis and the HPA axis. I'll briefly kind of go over a broad differential diagnosis of adrenal gland hypofunction or adrenal hypocorticism, just to give you a broad picture of kind of things you could think about that fall under that differential diagnosis. Not that we're going to talk in detail about every single one of those things. How you would go about working up adrenal gland hypofunction, and I'll go through kind of 3 cases that are actually 3 of my real patients. And as well with those cases, we'll talk a little bit about treatment of adrenal hypofunction depending on the etiology, as well as adrenal crises and chronic therapy. So if you guys, because I can't see all of you, so I can't tell if you have questions, but feel free to interrupt me in between. If you have questions, just say, hey, Dr. Nye, and I'll be quiet and listen to your questions. So feel free to ask questions if something isn't clear. So just a basic review of the anatomy of the adrenal gland. So of course you have your capsule on the outside, and then your adrenal cortex, and then your adrenal medulla. And when you get to the histologic view, you've got, there's your capsule, and then within the cortex, remember, you've got your 3 layers, your outer layer, which is your zona glomerulosa, middle layer is your fasciculata, and then your inner layer of your cortex is your reticularis, and then of course your medulla on the inside. When I think about the adrenal gland, even though we kind of group the cortex and the medulla together, I think it's better to think of them as separate organs, because embryologically they come from very different places, different cell types, and they function very differently. And so, of course, we've gone through those 3 layers of your cortex. And so just remember, your glomerulosa is where your mineralocorticoid is produced, so aldosterone. Your fasciculata is your cortisol, and then your reticularis is your sex steroids, with the primary one being DHEA. And that can, of course, be converted to androstenedione. I'll show you that whole profile in a minute within the adrenal gland. And I think you guys know the salt, sugar, sex mnemonic, like the cortex is like a margarita. You start with salt on the outside of the rim, and then you hit sugar in your sweet and sour mix. And then you go home and you have sex. So if you don't know it, there it is. It's probably not PC, but helps me remember it. Sorry. And then your medulla, which is where your catecholamines, your epi and your norepi are produced. So I know you've seen this profile before. It's drawn in different ways, but I like this way because it helps me think about the different layers of the cortex and what's going on in each one. So remember, within your adrenal cortex, everything starts as cholesterol. And in a multi-step process in your glomerulosa, you go to aldosterone. Or in the kind of upper steps of that process, you can shunt over to your fasciculata and go down and make cortisol. Or shunt over to your reticularis, and that's where DHEA and then androstenedione. And then androstenedione can be converted to testosterone, but that doesn't happen in the adrenal gland. That can happen in the ovary and the testicle, but the adrenal gland can only make DHEA or androstenedione, and then in the periphery is where testosterone can be made from the androstenedione, just as an aside. So again, glomerulosa, fasciculata, reticularis. So I don't expect you to memorize these. You know, I memorized them before my PEDS boards. I remember distinctly sitting in my car outside of a Prometric testing center before my PEDS endocrine boards with this in front of me, like going through it in my head, like, okay, just remember this. And now I just remember it, but I don't expect that you guys, well, maybe you do, but I don't expect that you know this off the top of your head. So just so you know the names of the enzymes, 2022 desmolase, that's 3-beta hydroxysteroid dehydrogenase, 3-beta HSD, and that's expressed in all 3 layers of your cortex. 21 hydroxylase is only expressed in the glomerulosa and fasciculata, as is, your 17 hydroxylase converts those 2 up there, and then 1720 lyase does that conversion. 11 beta hydroxylase is in your glomerulosa and fasciculata, and then aldosterone synthase is only in your glomerulosa. So we're going to touch on some of these enzymes, not all of them, when it comes to pathology. So a little bit of physiology about how these systems are controlled, and I think this is probably a review, but maybe more a review for some of you than others. So remember, aldosterone secretion is not controlled by the pituitary and ACTH. Aldosterone secretion is controlled by the renin-angiotensin-aldosterone system. So you're at your kidney, and in response to a decrease in perfusion to the kidney, renin is produced. Renin causes conversion of angiotensinogen in the, sorry, let me take that off the hook. 1 second. Angiotensinogen, renin converts that to angiotensin 1. I'm so sorry. I cannot. Can you guys hear my phone? I'm gonna have to unplug it. So, angiotensinogen is converted to angiotensin 1. And then ACE from the lungs converts angiotensin 1 to angiotensin 2. Angiotensin 2 acts to increase sympathetic activity, cause arteriolar vasoconstriction, and thus increases blood pressure. It also acts at the level of the pituitary and causes ADH secretion, which can increase volume, water, from the collecting duct of the kidney. And then, more important into this lecture, it acts at the adrenal cortex to stimulate aldosterone secretion. And then all of those things combined, and specifically with aldosterone, it causes sodium reabsorption and thus can increase blood volume and potassium excretion. But all those things combined, of course, are going to cause salt and water retention, increase renal perfusion, and then that feeds back at the level of the kidney to suppress renin once it's normalized. So hopefully a review. So focusing on the cortex and aldosterone secretion, just to start, in the setting of adrenal hypofunction. So for whatever reason, whatever the pathology, if you knock out aldosterone, you're going to have a low sodium and a high potassium level in the blood. And that's what we would refer to as a salt wasting crisis, like that we would see with adrenal insufficiency. So that is your glomerulosa's control by the renin-angiotensin-aldosterone system. Your fasciculata, where cortisol is made, is controlled by your pituitary gland in the HPA axis. So that your hypothalamus makes CRH, or corticotropin releasing hormone, and that acts at the level of the anterior pituitary to cause production of ACTH. And then ACTH, of course, then stimulates your fasciculata to cause production of cortisol. And then cortisol can feed back, of course, on the central, the hypothalamus and pituitary. I don't know if I have a slide on this, I can't remember, but just as an aside, the reticularis, the zona reticularis, where your sex steroids are made, we don't know, and by we, I don't mean just me, we don't know what controls that, whether it's something to do with ACTH or whatever, but whatever turns that on and causes us to start making sex steroids around the time of puberty or before with pathology, we don't fully understand. So back to the HPA axis, and I think you guys know this, but Remember that secretion in the HPA axis, maximum secretion of CRF occurs about 4 a.m., ACTH 4 to 6 a.m., and then cortisol 8 a.m. Now, if you've got someone that's worked the graveyard shift for years or has insomnia and is up all night and sleeps all day, this can be reversed in certain people. But in the typical person, this is kind of when you're going to see maximum secretion of these. And so if we're doing a cortisol level in an infant or an infant older than say 3 to 6 months or a child adolescent, we usually would do an 8 a.m. cortisol to try to catch a peak in secretion as opposed to a trough. You can still catch a trough. It's just you're more likely to catch a peak at 8 a.m. than a trough. ACTH and cortisol are released in pulses every 30 minutes to 2 hours throughout the day. And like I said, the pulses are greater in frequency and amplitude in the morning, and that's why you're more likely to catch a peak. And as I was saying before, the 3 to 6 month old kind of cutoff is before age 3 to 6 months, you don't really have this diurnal pattern in cortisol secretion. So technically in like newborns and less than 3 to 6 months, you should be able to just check a cortisol at any time and you have the same chance of getting a peak at any time of the day compared to a trough. But after 3 to 6 months, it's better to do it at 8 a.m. when that diurnal pattern gets established. So the peripheral effects of cortisol on the body. So remember in the blood, about 3/4 of your cortisol is bound to a carrier protein called transcortin. 15 to 18% is bound to albumin, and only about 7 to 10% is free, and that's your active form. So in states where you have low protein, you can have falsely low cortisol levels, and in that setting, sometimes it's better to look at a free cortisol. But so cortisol effects on the peripheral target tissues. It's going to act at the setting of liver and muscle. It's a counter-regulatory hormone to insulin, so it's going to act to raise blood sugar by increasing gluconeogenesis or glycogenolysis in the liver and muscle tissue. Someone called, I had a lot of phone calls today. Someone was calling me about a hypoglycemic baby earlier today. And the cortisol level was high when the baby's blood sugar was less than 40. I don't remember exactly what it was. And that is a normal response to a low blood sugar. Your body would increase cortisol production in an effort to raise the blood sugar. Similarly, glucagon and growth hormone and catecholamines would be secreted as well in an effort to raise blood sugar. Cortisol also acts at the level of the, it enhances the effects of epi and norepi on the vasculature. And so in that way, it actually modulates our blood pressure. And so that's why with adrenal insufficiency, you can see hypotension because you have less effective catecholamines on arterial constriction. Cortisol causes alteration in the balance between osteocytes and osteoblasts. And so you actually get decreased bone formation. And that's why people that are either making too much cortisol or on high dose glucocorticoids can have osteoporosis because of decreased bone formation. And then cortisol does a lot of things in the area of anti-inflammation. You know, it's all listed there. It's not like you need to memorize that, but it does have a lot of anti-inflammatory effects. So, and this is what I was saying before, I just couldn't remember if I had a slide on it. So we don't know what the regulators are of the adrenal androgens. We know that fetal adrenal glands are actually pretty large compared to child or adults. Their fetal adrenal glands are bigger than our adrenal glands, and then they kind of get smaller after the baby's born and the baby starts to grow. But so DHEA and DHES, if you were to measure them in like a neonate, they'd actually be pretty high, and then they fall to kind of normal ranges shortly after birth and stay that way until adrenarche occurs around pubertal age. We just, again, don't know the signals that stimulate adrenarche around puberty. So if you guys remember the POMC or pro-opiomelanocortin gene, it's from this gene that ACTH is made. So you've got this big POMC gene, it gets transcribed, and you've got this big protein that gets post-translationally processed, blah, blah, blah. And
yeah, she's like this. I was like, is she
Can you guys hear me? I just heard talking. Can you hear me?
We can hear you.
Oh, okay. Sorry. So it gets post-translationally processed and ACTH is made. And another byproduct of that is MSH. So that's your melanocyte stimulating hormone. And so this is where I think one of the reasons it falls under skin disorders is with anything that causes lower cortisol production and thus decreased negative feedback at the level of the pituitary. So ACTH is going to rise. So anything that causes excessive ACTH production can also cause excessive MSH production and thus skin hyperpigmentation. So a big differentiator here is you will see skin hyperpigmentation with primary adrenal insufficiency, so at the level of the adrenal gland, because you have low cortisol and a high ACTH. But with central, whether it's secondary or tertiary in the pituitary or hypothalamus, you won't see skin hyperpigmentation with adrenal insufficiency because in those settings, ACTH level is decreased and so is MSH. So that's a good differentiator. You've got someone with adrenal insufficiency as to where it's coming from, at least on exam, is whether or not there's skin hyperpigmentation. The patients that I've seen with adrenal insufficiency that have had this look like, they've been at a Caribbean resort for a week. They're super tan pretty much everywhere, and that's different than their normal. One girl actually had a really tan tongue. It was like black in areas. That was a few years back, and then it went away once we treated her. But in the earliest forms, the places I look, if it's not full body, are going to be like the palms and soles, the creases, or kind of any of the antecubital areas and things like that. But again, it often is full body if it's progressed long enough, and then lightens up as you treat. So just basics of adrenal insufficiency symptoms before we get into a differential diagnosis. So with glucocorticoid deficiency, because that does act to raise blood sugar, so if you're deficient in cortisol, insulin is less opposed. So you can see hypoglycemia or increased insulin sensitivity. So if I have a patient with diabetes, type 1, who is having unusual low blood sugars that I can't explain, I do consider other autoimmune disorders like Addison's disease, because if they're on the same amount of insulin and now all of a sudden they're dropping low, it could just be because insulin is less opposed because they're not making enough cortisol. So anyway, something to think about. I mentioned that your cortisol modulates your catecholamines effects on blood pressure, and so you can see hypotension, nausea, vomiting, fatigue. With mineralocorticoid deficiency or a salt wasting crisis because of low aldosterone, you can see muscle weakness, nausea, vomiting, anorexia, fatigue. Salt craving. So I'll get into this in one of the cases, but I have a patient who, I can't remember, I think he was 11, it's in the case, but he was diagnosed with Addison's disease, and before diagnosis, his friends at school called him Pickle Boy because all he wanted to do was eat pickles and drink pickle juice, and that's because he was craving salt. With the lower sodium, and you have decreased blood volume, so you can see hypotension associated with aldosterone deficiency as well. And then, of course, as I mentioned before, hyperkalemia, hyponatremia. With the hypotension and poor perfusion, you can have acidosis. And then adrenal androgen deficiency, so your sex steroids may cause diminished or no adrenarche, decreased libido in an older child or adolescent, which isn't always a bad thing, depending. And then, like I said before, the increased MSH levels, you would see skin hyperpigmentation, and that's just with primary, not with secondary or tertiary. So just again, this is a really broad differential of adrenal insufficiency. I'm going to talk about congenital forms, which by that, I don't necessarily mean that they present at the time of birth. I mean more they're genetic related things as opposed to acquired forms, and then secondary and tertiary forms, which I'll get to those on the next slide. So under congenital forms, I think, we're all kind of familiar with congenital adrenal hyperplasia, or CAH. And on the next slide, I'll talk in more detail about that. But the most common causes of CAH are going to be a 21 hydroxylase deficiency or an 11 beta hydroxylase deficiency. Different from congenital adrenal hyperplasia is congenital adrenal hypoplasia, which is not the same as CAH. We usually call it adrenal hypoplasia, so there's no confusion. And there's different forms of that. There is an X-linked form where the adrenal glands just don't form. A star mutation, if you remember that steroid biosynthesis picture, the very first enzyme was the star one. And so if you're deficient in that star enzyme, that's allowing cholesterol to kind of transport into the adrenal gland to be processed to form all your hormones, then you can't make any of your hormones. So your adrenal glands are smaller and you're deficient in all of them. These are rare. And I'm not going to go into a huge amount of detail on these, but image association, I don't know if you guys are familiar with that at all. I've only seen it once in my career, and it was actually in fellowship. It's an association. So it's IUGR, metaphyseal dysplasia, adrenal hypoplasia, and GU abnormalities. So the little boy I saw in fellowship was just after birth. He was African-American, but his family was kind of lighter skinned African-American. And he was the darkest baby I have ever seen. He had the most skin hyperpigmentation I've ever seen. So he had adrenal insufficiency, but along those lines, he was IUGR, and then he had like a microphallus and I think undescended testes. So there was some GU abnormalities. And they're learning more about the genetics of this, but I don't know that it's completely understood. It's associated with some genes, or some genes have been identified to cause this, but they don't know all the genes that cause this. I think you're more familiar with the autoimmune causes. So you can just have Addison's disease, or you can have Addison's disease as part of one of your autoimmune polyglandular syndromes or your APS syndromes. Remember, I don't know if I have this. No, I don't. So type 1, they like these kinds of questions on shelf exams and boards, and you really just have to know the triad. So APS type 1 is a triad of, they say mucocutaneous candidiasis, but it's because of autoimmune neutropenia, you get fungal infection, Addison's disease, and then autoimmune hypoparathyroidism. And then APS type 2 is a triad of type 1 diabetes, Addison's, and autoimmune thyroid disease, whether it's Hosh or Graves. And I'm not going to go into detail other than on one of these, your metabolic lipid disorders, adrenal lipodystrophy, adrenomyeloneuropathy, and then woman's disease, which is acid lipase deficiency. So just kind of a broad differential of what you might think about with adrenal hypofunction from a congenital perspective. Acquired forms. So you can have adrenal hemorrhage related to different things. So sometimes with a traumatic delivery in the newborn period, you can actually have hemorrhages in the adrenal glands related to bacterial infections. So Waterhouse-Friderichsen syndrome, you can have bacterial seeding and hemorrhage into your adrenals. If you have low platelets or you're being treated with heparin and obviously blood thinning, you can hemorrhage in different places, but one of them is your adrenals. From an infectious perspective, this might have been on my PEDS boards, but I can't remember where this was asked. It was like, what's the most common cause of adrenal hypofunction worldwide? And worldwide, it's actually TB. Obviously not in the US, but worldwide, it's TB. Fungal infections, HIV. We don't see these a lot in kids, but these types of things, if you have protein deposition and things like that in your adrenal gland, or yes, you can have adrenal hypofunction related to like amyloidosis, histiocytosis, sarcoid. And then with tumors like adrenal adenomas or adrenal carcinomas can be secretory, meaning they secrete one or more of the adrenal hormones, but that would, of course, be a hyperfunctioning adrenal gland. So if a tumor is going to cause adrenal hypofunction, it would be like a mass effect. and it was causing, cellular apoptosis and things like that in the cortex. You could have hypofunction related to that. And then your secondary forms, which there's a 1-year-old on the floor right now, I think that y'all are kind of working up for this. But congenital malformations like septo-optic dysplasia or holoprosencephaly, those types of things where the pituitary gland, it's a midline defect, so the pituitary just doesn't form right. If a child's had tumors or radiation treatment to the head, you can see it related to the tumor itself, again, with like apoptosis or infiltration, and then, of course, as a side effect of surgery or RT. Again, with those unusual types of disorders that we don't see a lot in kids, you can get deposition of things within the pituitary or hypothalamus, and that can lead to hypofunction. Never seen congenital aplasia or hypoplasia of the pituitary. That being said, I have seen pituitary ectopia, where the pituitary just doesn't form in the right place and therefore doesn't function right. Same type of thing, different tumors, radiation treatment. There is an autoimmune form of hypopituitarism. We don't clinically have antibodies that we can check against the pituitary, so this is something that I've never diagnosed, but it is out there. And then, of course, if as a physician we're treating a patient with high-dose glucocorticoids and we don't taper them, we can cause adrenal insufficiency. Textbook is like if someone's on steroids for more than 11 to 14 days, plus or minus, then they're at risk for adrenal insufficiency. And so the steroids should be tapered as opposed to just stopped, compared to if they're on it for a shorter duration in general, they can be just stopped and you shouldn't have adrenal insufficiency symptoms. If you remove a tumor, so if you have an adrenal tumor on one side, especially if it's secretory and making a ton of cortisol, you can actually get atrophy of the other adrenal gland because you're overproducing in one. And so once you take that adrenal gland out, you can have adrenal insufficiency until that other adrenal gland recovers. And then if mom's on high-dose glucocorticoids for whatever reason, it can cause suppression of the baby's adrenal glands. So it's just something to think about if there's a history in pregnancy of that. So getting a little bit more into pathology and some of those disorders that I just broadly reviewed. So again, I'm going to go through 3 cases, and these are real patients of mine. This one I actually just saw in clinic today. So when I initially saw her, she was a newborn, full-term baby. Day of life 1 is when I was consulted, and the mom was actually a nurse in Prisma, is no longer, not because of this. But anyway, it was an uncomplicated pregnancy. Birth weight was normal. On prenatal ultrasound, they told mom that the baby was a girl. But when she was born, that's what her genitalia looked like. And so she clearly appeared more male. And I'm saying she now, I did not use the term she right away. She clearly appeared more male with a phallic structure and a fused scrotal structure, but you can tell it sort of wraps around the phallic structure, almost like labia would wrap around a clitoris. And when you palpated the scrotal structure, there were no testes palpable. And so this is why I was consulted, was because we had ambiguous genitalia and what was believed to be a female prenatally. So as an aside, they had already done these labs just as part of their routine newborn stuff. So we know she had a normal sodium and a normal potassium on day of life 1, but she did have some hypoglycemia on day of life 1, but it responded very easily to glucose. And so once they gave her a bolus and put her on dextrose containing fluids, her glucose remained normal after that. So when I evaluate a baby for ambiguous genitalia, or well, any age really, my first question is, do I think I'm dealing with a virilized female or an under-virilized male? And this could be either, right? So this could either be a female that looks more male because of androgen something, or this could be a male that didn't make enough androgens and therefore is ambiguous because couldn't get all the way to the male anatomy. And in another slide, I'll kind of show you how that progresses embryologically. And so just things that I think about in the newborn period, if I'm leaning more towards a virilized female, classical CAH, I put in capital letters because that is the most common. I would just say that's 1, 2, and 3 on the differential diagnosis of a virilized female in infancy. But if not super common, if there's a virilizing tumor in the newborn, like of the adrenal or the ovary, there are virilizing tumors in pregnant females like lutiomas and things like that, where the mom can actually overproduce androgens herself during pregnancy, and then that causes virilization of the fetus. But usually there'd be something on history, like mom developed hirsutism or something unusual related to virilization during the pregnancy. If there's none of that, I'm not super concerned about a virilizing tumor in mom. If I'm thinking more under virilized male, then there's different things that I'm not going to get into. This is a whole nother lecture, but things like Klinefelter syndrome, 5-alpha reductase deficiency. So remember, 5-alpha reductase converts testosterone to dihydrotestosterone. Aromatase deficiency, aromatase converts testosterone to estrogen. And then there are some rare undervirilizing forms of CAH. So if you remember from that biosynthesis profile, I showed you that 3-beta HSD that's expressed in all 3 layers of the cortex. If you're deficient in that, you can't convert DHEA to androstenedione, so you can't make androgens normally. And so that would present as an undervirilized male, but not very common. So in this case, I was leaning more towards a virilized female because of the history on the prenatal ultrasound, but also because there was no testes palpable in the scrotum or the scrotal structure. So if there were testes, this is a male. No doubt it would be an undervirilized male, but without testes, I'm leaning more towards a female. And so the first thing and the fastest thing that we can do is an ultrasound to make sure that there's no testicles like in the inguinal canals or anywhere that we can see, because that helps us very quickly decide if we're dealing with a male or a female baby. And so on the ultrasound of the pelvic and the scrotal structure, the child was noted to have a small uterus, what looked like ovaries in a normal location, and there was no testes in either the inguinal regions or the scrotum. So from that, I felt comfortable that this was a virilized female. And so that's what I talked to the family about, is that that's one of the most difficult things, in my opinion, is having a discussion with the family and not being able to use a gender when you're describing the child. And I think that's also one of the most disconcerting things to the family, is not knowing what gender their baby is. And so I think the more rapidly but accurately that you can give them those results, the better. So I had a discussion with mom around this time that that she was virilized, but that the child was a girl, and that the most likely cause was a classical form of CAH, but that we would be looking into other things. And so, of course, we did these labs right away too, but they don't come back right away. So, but I don't know if it's later that day or the next day, her 17-hydroxyprogesterone, and I'm going to bring this home for you in a minute with the steroid biosynthesis profile picture again, but her 17-hydroxyprogesterone was severely high. It was 12,400. And then because of loss of negative feedback of cortisol on the pituitary, her ACTH level was also elevated. On my PEDS boards, they gave a clinical vignette that was somewhat like this, like a virilized female, and you could deduce that they were talking about a baby girl with CAH. And they said, what's the most likely karyotype? And the answer is 46XX. And they were just trying to make sure you understood that CAH is not an XY issue. It's a adrenal enzyme issue. So keep that in mind. On the Y chromosome is the SRY region, which is kind of like the gender determining one of them region of the Y chromosome. And sometimes there can be chromosomal translocations where even if you have an XX karyotype, there can be a translocation of this SRY region onto one of the X chromosomes. And so when we're trying to decide gender of a baby with ambiguous genitalia, a lot of times we'll order a fish for the SRY region, which we did in her case before we had all this stuff back, and it was negative. So we knew she didn't have an SRY region. And so this is a typical presentation for CAH, or congenital adrenal hyperplasia, which is an autosomal recessive disorder. Just basic info, the incidence in children less than a year is about 5.5 in 100,000. There is a non-classical type that presents later, which we'll talk about, which has a little bit of a lower incidence. In more than 90% of cases of CAH, it results from a 21-hydroxylase deficiency. And so whether it presents in infancy or later, more than 90% of the time, it's from a defect in this enzyme. 5% of the time, it's from a defect in 11-beta hydroxylase. And then the remainder of the 5%, it's one of these other rare forms. And so back to this picture, these are your two most common causes of CAH. So again, 90% of cases come from a 21-hydroxylase deficiency. And so if you're looking at this picture, if you're deficient in 21-hydroxylase, 17-hydroxyprogesterone, the precursor, is going to build up in the blood. And so that's why the newborn screen in every state uses 17-hydroxyprogesterone as the test for CAH, because in more than, well, in this, I'll explain, but in more than 95% of cases of CAH, it's going to be elevated. And then, of course, if you're deficient in that, your precursors are going to build up and you're going to shunt over to your sex steroids, and that's so you get androgen overproduction. And so in a boy, you don't see virilization with CAH when they're born. They just look like a boy because they already would have made androgens. They're just making them at higher amounts. You don't like see pubic hair or anything like that in the neonatal period. It's the girls that are going to look virilized and have ambiguous genitalia. 11-beta hydroxylase, which, like I said, is about 5% of cases of CAH. I think I point this out. So with either of these, you can be variably deficient in cortisol and aldosterone. With 11-beta, do I point that out? I don't think I do. With 11-beta hydroxylase, if you look at the glomerulosa, the differentiating factor between a 21-hydroxylase and an 11-beta hydroxylase, with the 11-beta hydroxylase, that precursor compound in red, 11-deoxycorticosterone, or we call it DOC, that's going to build up to high levels with an 11-beta deficiency, and that would be low with a 21-hydroxylase deficiency. And DOC has a high mineral corticoid activity, so it has a high like aldosterone-like effect. And so you can get sodium retention with DOC being elevated, and that can cause hypertension. And so on a test, if they gave you a clinical vignette that just looked like CAH and they said, what's the most likely diagnosis? The answer is going to be a 21-hydroxylase deficiency. But if they gave you that same clinical vignette and the baby was hypertensive and they said, what's the most likely diagnosis? The answer is going to be an 11-beta hydroxylase deficiency. So I hope that makes sense. So there are two broad categories of CAH. There's your classical, which is the one that we think about that presents in the newborn period or in early infancy. And under classical, there are your simple virilizers and your salt wasters. So your simple virilizers are going to remember, a gene defect isn't all or nothing. Some gene defects are going to cause more hormone deficiency than others, or less activity of the protein that's made from the gene. I hope that makes sense. I can't see your faces. And so a simple viralizer is going to make enough aldosterone to get by, so they don't have salt wasting, but they don't make enough cortisol, so they're still shunting over to their sex steroids. And again, boy would look boy, but present later in infancy or childhood, probably with pubarchy. And a girl would have some sort of genital ambiguity because of the androgen overproduction, but they don't have the low sodium, high potassium, and the salt wasting crisis. And then your salt wasters are going to be the combination of both, where you have viralization because of cortisol deficiency and androgen overproduction, and then you have aldosterone deficiency. And then the second part of that broad category would be your non-classical CAH. And those ones are less severe. You don't see aldosterone deficiency in general with those. You just have cortisol deficiency to varying degrees, and so you have androgen overproduction. And so that can present in later infancy or childhood with premature adrenarche or pubic hair before the age of 8 in a girl or before the age of 9 in a boy. And it can even present in adolescence with like a PCOS-like picture in girls with hirsutism and either amenorrhea or irregular menses. And that was the DOC point I was talking about. So I went through a lot of this, girls, boys. So the salt wasting crisis in CAH, because I told you in this case, the baby's electrolytes were normal on day of life 1, and that's good, but it doesn't matter because the salt wasting typically doesn't present itself until about 1 to 2 weeks of life with CAH, which unfortunately is when the newborn screen is also coming back. So CAH can be a little bit more dangerous with boys because we don't know they have CAH until they salt waste, and they come in for that reason. Whereas girls, we usually pick it up early because of genital ambiguity. So around 1 to 2 weeks with a salt waster, they often would present with poor feeding and lethargy, seizures, of course, with hyponatremia, that kind of stuff, if it's not treated before then. Your non-classical, I mentioned isolated adrenarche, and we see isolated adrenarche a lot, and it more commonly is benign than it is CAH. And although I may work it up, to think more about CAH, I'd have to see adrenarche along with things like voice deepening or increased muscle mass, like when a boy goes to puberty, an advanced bone age because of sex steroid effects on physical maturation, and then in girls, clitoromegaly. From a pubertal perspective, like I already said, it often can present like a PCOS type picture, that non-classical form. And so again, because 21 and 11 are the ones that primarily cause CAH, so 95% or more of cases are going to have an elevated 17-hydroxyprogesterone. And so that is typically the screening test for this. If for some reason that result is borderline or it's not clear if they have CAH with everything, there are times where we might do what's called a high dose ACTH stimulation test. You guys may have been involved in a low dose one, which we do in the NICU a lot for when there's a question of like central adrenal insufficiency in a baby. With the low dose, we're typically giving 1 microgram of cortrosyn, which is a synthetic form of ACTH. The high dose, we use 250 micrograms of cortrosyn. And we measure like a adrenal profile before we give the cortrosyn, and then we measure an adrenal profile after. And we look not only at absolute values, but we look at ratios. Like when you go back to that biosynthesis profile, we might look at the ratio of 17-OHP to cortisol, because we'd expect that ratio to be high with CAH because the 17-OHP is higher than the cortisol, which you can't make enough of. And then there's other ratios that we actually look at to help us figure out, 1, if CAH is present, and then 2, what form of CAH is present, depending on like which ratios are elevated, can kind of tell you where your deficient enzyme is. So, let me go back. So just about embryologically, I just think this is important when you're evaluating a baby with ambiguous genitalia to kind of know how things would normally progress, because it helps you know what to look for. So remember, before 6 to 8 weeks gestation, we're bipotential. We can go girl or we can go boy. So our gonads look the same, and our external structures look the same. And then around 6 to 8 weeks gestation, depending on which signals we have in our body, if we have like an XX versus XY, and then there's other transcription factors outside of that that are important. But if all the signals are there to go male, then we become a male. If the signals are not all there, the default, and I don't say that to be funny, it's just true, the default is female. And so if there's an abnormality in the signals, the child will become a female. And so when we're bipotential, and sorry, I can't point. I don't think I can. Can you guys see my arrow? Well, I'm going to pretend you can see my arrow. So,
Yes, we can see it.
Okay, perfect. So when you're looking at this structure here, when we're bipotential, it's called a genital tubercle. And then these structures here are called labioscrotal swellings. These structures here, the little ones, are called urethral folds. And then this structure here in the middle is the urethral groove. Of course, you've got your anus. And so if the signals are all there to go male, then the genital tubercle becomes the glands of the penis. The labioscrotal swellings fuse posteriorly to become the scrotum. The urethral folds fuse circumferentially to become the shaft of the phallus. And then the urethral groove in the middle is the penile urethra. And then if the signals aren't all there and the baby becomes a female, the genital tubercle becomes the clitoris. The labioscrotal swellings stay open and are the labia majora. The urethral folds stay open and become the labia minora. And then that urethral groove in the middle partitions, and the ventral portion becomes the urethra, and the dorsal portion becomes the lower third of the vagina. And then remember, the upper 2/3 of the vagina comes from your Müllerian structures and your internal reproductive structures. So I think this is helpful to kind of think through that, because to varying degrees, things I look for, of course, are like clitoral, well, we'll say an enlarged genital tubercle structure, if you don't know if you're dealing with a girl or a boy. And so that could be a clitoris, or it could be a penis, right? So you could have a microphallus, or you could have clitoromegaly. To varying degrees, you can have underfusion of the scrotum. And so sometimes you'll see it looks like a scrotum, but it's not fused at all. Like it's got that rugation, the hyperpigmentation of a scrotum, but it's totally separate. Or you can have partial fusion where the bottom portion is fused, but the top isn't. So there's different things. But anyway, I think it's just helpful to know embryology to understand what you're looking at when you're looking at genital ambiguity. So maintenance of adrenal hypofunction in this setting of CAH. So the normal adrenal gland in the typical person is going to put out 5 to 7 mg per meter squared per day of cortisol, or hydrocortisone equivalent. And so we'll just go in the middle and say 6. So the normal adrenal gland at maintenance puts out about 6 mg per meter squared per day. So if we're replacing maintenance IV, we would give 6 mg per meter squared per day, and we just divide that every hydrocortisone every 6 to 8 hours. The bioavailability of oral hydrocortisone is 50%. So if you're giving hydrocortisone orally, we just double it because only half is absorbed. So when we're giving maintenance dosing for adrenal insufficiency, we usually orally we give 12 mg per meter squared per day. And I think it's good to think about the different forms of steroids that are out there, because they have different potencies. So Hydrocortisone, if we consider that a 1, just because it's the least potent and we're going to compare everything else to that, it has a biologic half-life of 8 to 12 hours, so it has the shortest duration of action. It's usually dosed 2 to 3 times a day. And we use hydrocortisone more in younger kids because it has a lower duration of, or lower duration of action. And so it has less like bone effect and growth suppressive effects. And then as kids get done with puberty and growth, we might go to something like prednisone, or in less rare cases, dexamethasone, when we're not worried about growth and things like that, because they have to be dosed less frequently, and we're more worried about compliance in that population. So we tend to use hydrocortisone in babies and younger kids for that reason, and may convert in older adolescents to prednisone or dex. Dex only has to be dosed once a day, prednisone's twice a day. Prednisone is about 4 times as potent as hydrocortisone. Methylprednisone is about 5, and then dex is about 20 to 25 times as potent as hydrocortisone. So if you're using one of those medicines for whatever reason to replace hydrocortisone or cortisol, then you've got to keep in mind their potency. And so if hydrocortisone maintenance is 12 mg per meter squared per day, then prednisone or meth is going to be about 2 to 3 mg per meter squared per day, blah, blah, blah. So anyway, it's just important to think about. Fludrocortisone is typically what we use to replace the mineral corticoids in aldosterone or in adrenal insufficiency. And that's because it really doesn't have the cortisol effect, because we don't want that. We are using hydrocortisone for that. It has really the most potent mineral corticoid effect. So we use fludrocortisone to replace aldosterone. So from a maintenance perspective with mineral corticoid, the secretion rate of aldosterone is about the same from 2 weeks old to adulthood. So I have patients that from the time I start seeing them until they graduate from my clinic are on the same dose of fludrocortisone. Sometimes we have to change it, but it's doesn't need to be adjusted as regularly as hydrocortisone does, which we see these kids with adrenal insufficiency probably somewhere between varies 3 to 6 months, but more likely it's every 3 to 4, just so we can adjust hydrocortisone to allow for normal growth and prevent adrenal crises as they get older. There's the dosing of fludrocortisone, not that you need to remember it. You can look at that up if you ever needed it. But babies' kidneys are wonky. They're not fully developed, and so they don't hold on to sodium really well anyway. So if you throw aldosterone deficiency on top of that, a lot of times fludrocortisone alone doesn't keep their sodium normal. So in the newborn period, a lot of times if we're treating adrenal insufficiency, we'll give sodium chloride in addition to fludrocortisone. And then as they get older, we wean them off of the sodium chloride, and they stay just on the fludrocortisone. And that's just if you're calculating how much salt to give someone, it's there for you. And so an adrenal crisis, there's very few emergencies in endocrine, but an adrenal crisis is one of those. And so with an adrenal crisis, there's just 2 things to consider. Not only are they dehydrated, but they could also be hypoglycemic and hypotensive from volume depletion. And so just from a treatment perspective, and you guys are closer to this than me in the ERs and the ICUs, but of course, like you'd consider a bolus of normal saline for hypotension, dextrose bolus to treat the hypoglycemia. And then until you have resolved the cortisol deficiency or aldosterone deficiency, they're going to need IV fluids to maintain a normal blood pressure. So for at least the next day or so, if not longer, keeping them on a pretty high volume of dextrose containing fluids. From a glucocorticoid deficiency perspective, what I talked about before was more maintenance. In the acute setting, if someone comes in and you're worried about an adrenal crisis, we usually give an infant 25 mg IV, child's 50, and then an adult's 100, just times 1 to get some steroids in their system. And those are pretty standard doses that are easy, I think, to remember. And then for maintenance steroid dosing, like if someone's acutely ill and so you want to keep them on stress steroids until they're clinically more stable, we usually do 50 to 100 mg per meter squared per day divided every 3 to divided 3 or 4 times a day. The truth is, though, I don't know that there's a right answer to stress dosing. Like a person who's stressed is going to make more hydrocortisone normally than a person who isn't. When they're at home, we usually just tell them if they're sick, but it's not like a hospital requiring sickness, just to triple their home dose of steroids. But in the hospital, we usually just do like 50 to 100 mgs per meter square per day. And that's pretty standard across most endocrinologists. And this is that same 12-month-old that I think we're evaluating for hypopituitarism. I was saying this already, but anesthesia or sedation is, for whatever reason, very stressful on the body. So if someone's getting surgery, or in this child's case, it's a head MRI under sedation, we do usually give a stress dose with induction of anesthesia, and then we continue the stress dosing if they need it post-procedure or post-operatively. Okay, I've got just a few. I'm going to run through this one pretty quick. So do you guys mind if I keep going, or should I stop? I keep going until someone tells me to stop. What was that?
You can keep going if you want. We're listening.
Well, if I'm the last, if there's no one in the room, if you're the last person in the room, then tell me so I'm not talking to myself.
Okay, sounds good.
So case 2, this is a 9-year-old Caucasian male presented to the ER with a 1-day history of altered mental status and a 2-month history of bilateral hip pain, pickle boy. And so in the ER, they got a set of electrolytes. He was hyponatremic, hyperkalemic, somewhat acidotic, and hypoglycemic. They did a random cortisol, which surprisingly to me comes back real quickly in the ER, but it was less than 0.5, so it was undetectable. The ACTH didn't come back till later, but with that random cortisol in that presentation, we were pretty sure he had primary adrenal insufficiency, especially with that skin hyperpigmentation. So he got a dose of, I don't know at that time, I wasn't in the ER, but he probably got 50 mgs of some sort of steroid IV or IM just for stress dosing, and then was started on, got a dextrose bolus, was started on IV fluids. And after the fact, because we sent all of these labs from the get-go, his ACTH was elevated, so clearly primary adrenal insufficiency with loss of negative feedback. We routinely, when they present as a child or adolescent with adrenal insufficiency, will do a 21-hydroxylase antibody. I mean, it takes like at least a few days to a week to get back, so it's not helpful in the acute setting. But his was pretty high, and so it was clearly an autoimmune cause for his adrenal insufficiency. When they present in childhood or adolescence with adrenal insufficiency, we typically will also do a very long chain fatty acid test, and that's to evaluate for adrenal leukodystrophy, which I'll talk about on a different slide, but this child's eventually came back negative. We didn't have that right away. So like I said, dextrose bolus, fluid bolus, steroid bolus, and then was started on replacement for those. So he was on Florinef and stress dose glucocorticoids initially, and then transitioned to maintenance once he was stable. So Addison's disease is probably the most common cause of adrenal insufficiency in the US in children or adolescents, not worldwide, that's TB. And it is cell-mediated or T-cell mediated destruction of your adrenal gland to varying degrees, more common in females like most autoimmune disorders. And in somewhere around 3/4 or a little less of patients with Addison's, you can detect the 21-hydroxylase antibodies. So it's a pretty good test to support a diagnosis of an autoimmune cause. Approximately half of people with Addison's will go on to develop other autoimmune endocrinopathies, so thyroid disease being the most common, about 1/4. So I mentioned this on one of the other slides, but adrenal or Addison's disease can present isolated, and that has a strong association with this human leukocyte antigen DR3 gene. You don't need to remember that. Or as I mentioned before, it can present with one of your APSs, type 1 or type 2. So adrenal leukodystrophy is related to the ABCD1 gene, which is X-linked. This is an X-linked recessive disorder. And that gene is important for producing a dimer that transports peroxisomes through cell membranes. And so with this, you can't metabolize very long chain fats normally. So you get elevation of these very long chain fatty acids, and they get deposited in various tissues. And one of those tissues is the adrenal gland. And so over time, you can have atrophy and death of your adrenal cortical cells. There's two major forms. There is a childhood form that has more cerebral issues, and then there's an older age non-inflammatory form. So with adrenal leukodystrophy, kind of this textbook clinical vignette is like a 7 or 8 year old that presents with, here I put unusual behaviors, but a lot of times it's like decreased school performance or maybe misdiagnosed as like ADHD. I've seen a couple of patients that have had diagnosis of ADHD and then went on to be diagnosed with adrenal leukodystrophy. They may have alterations in visual acuity because of deposition in the eye of the long chain fatty acids. They get loss of muscle strength and limbs. And then over a period of a few years, dementia, blindness, quadriparesis, and death. So I don't think they can do bone marrow transplants in this disorder if it's caught early enough. But we are involved not so much for the neuro part of it, but we treat the adrenal insufficiency just like we would treat Addison's or whatever else with maintenance steroids and then fludrocortisone if they have salt wasting. And so last case, and then we're done. Interesting case, 7.5-year-old African-American male. He presented to my office actually for abnormal thyroid function. And when he came in, this was his thyroid function. So free T4 was undetectable and his TSH was also low. So this clearly looks like central hypothyroidism. He had been seen by his PCP a few weeks earlier for drinking more, constipation, a lot of headaches, and he was having difficulty walking upstairs and was otherwise a normal kid before this. So his first visit with me, he did have polydipsia. He was drinking a lot, not just on history, but actually when you quantified it, he was drinking a lot. He had this new onset nocturia once a night and had a couple episodes of nocturnal enuresis, whereas previously that wasn't an issue for him. Constipation, fatigue, and he was having problems bending, squatting, and walking up and down stairs. So basically like proximal muscle weakness. And on my exam, and again, this kid's 7.5, he had late Tanner stage 3 pubic hair. His testes were still pre-pubertal. They were 3, not 4, but his stretched penile length was 7.5 centimeters, which was large, greater than the 90th percentile for his age. And there are standards for that, boys, in case you didn't know. And so I repeated some labs, of course, and he clearly had a low free T4, total T3. His TSH was normal in this case, but it had been low previously. His fasting cortisol was 5 at 8 a.m. Normal's really above 15. And despite the fact that he was clearly having some pubertal changes, his testes being small, his LH and FSH were prepubertal. His testosterone was through the roof for a prepubertal boy. Well, even for a pubertal boy, that's really high. And then quantitative serum beta HCG was also elevated. So growth factor levels were normal. So with this history, which looked like hypopituitarism with gonadotropin independent precocious puberty, because he's making testosterone, but it's not because of LH and FSH production. It looked like an intracranial abnormality. So we went ahead and got a head MRI, and he had a pretty large mass, which ended up being a germinoma in his brain. And so the germinoma was producing HCG, which interacts with your LH and FSH receptor. So it causes gonadotropin independent precocious puberty. So anyway, Dr. Kramer with HEMONC saw him. He had chemo and RT and is in remission at the moment. But he post-treatment, and actually I think because of destruction by the tumor, but then also the radiation therapy, he has longstanding hypopituitarism now. So he has DI, central adrenal insufficiency, central hypothyroidism. With treatment of the tumor, the HCG level normalized. So his puberty has stopped and actually regressed some. Well, now he's pubertal age, so he's starting his own puberty, but he had central adrenal insufficiency related to this tumor, and we replaced his cortisol, his hydrocortisone, but he's not going to have salt wasting because it's not primary. He doesn't have a problem with his adrenal gland itself. It was at the level of the pituitary and hypothalamus. So we just were doing hydrocortisone replacement. And that's it. Here's my daughter and son. Any questions for those of you that are still around?
None from the NICU. Thanks, Dr. Knight.
Yep, no problem. Have a good day, guys.
You too.
Dr. Knight, sorry, I'm late to the game.
It's okay.
So I was curious, long term, do patients with CAH, do they typically identify as male or female with their gender?
Yeah, so most common is that they identify as their actual gender. But I think there is a higher incidence of transgender in the CAH population, more so, I shouldn't say with both, with girls who have CAH, because and the thought is, well, it's not a thought, it's a fact, they're exposed to a higher level of androgens in utero. There is a higher incidence of transgender in the CAH population of girls compared to just normal population of girls. And so there is some speculation that the androgen exposure in utero may predispose to a discrepancy between their biologic and perceived genders. But again, most common is that they identify as their actual gender, if that makes sense.
Thank you. Do you guys counsel parents on that? Do you let them know that they have an increased risk? I mean, I don't know if risk is the right word, but.
I know what you're saying. Not usually like in the hospital, no, but in outpatient, we talk about different kinds of things like that as a child, because, we see them so frequently, and it's not usually an issue right away, but as the child is getting a little bit older, it is. And so it's something that I do typically bring up, and I usually just say exactly what I just told you, that usually they identify as their karyotype gender, but that there is a higher risk of transgender in that population. So one thing I'm not super clear on, like that case that I presented of the girl with CAH, I just saw her today, and she's 6 now and doing well. She had vaginoplasty with Dr. Arith of urology, and actually her GU exam looks very female and normal now. They did a good job with that surgery, but I'm interested to see if there's any problems when she gets older with menstruation. I mean, the connections are all normal now, and she has a normal uterus. She always has. It's just, I don't know if like the vaginal outlet, if something's going to be different with that. And then, and I don't know that she'll get to this point while I'm seeing her, but I see kids till they're 18 or 19, and then with like sexual intercourse, what to expect. And so mom was actually, because mom used to be a nurse, well, she still is a nurse, she just does not Prism anymore, was asking me about adolescent GYN and like when to get her linked into that. And I'd probably do it, not now, she's 6, but in early adolescence, just to get her established. And I'm not real sure what to expect with that. I'm sure it varies from person to person, kind of the outcomes with sexual intercourse.
I'm surprised then that if they have an increase, transgender, that they wouldn't hold off on surgery, vaginal surgery or, any reconstruction until later on, in case, they would prefer, to become male instead of fixing and becoming female, if that makes sense.
Yeah, and so that's actually a good question or point. If you read any of like the endocrine consensus guidelines as far as genital ambiguity goes, um, it's not a black and white area, but they kind of say that it's not a bad idea to, with genital ambiguity, especially if it's not, if it could go either way, to not make decisions early on and wait until the child's older and see kind of what gender they identify as, before doing any sort of definitive surgeries. CAH, though, I would say is the exception. And although if a family was very progressive in that area and wanted to hold off, I wouldn't be averse to it from a surgery standpoint. But because most girls identify as girls and boys identify as boys, the recommendation is that you treat them as such now. I don't know if that'll be different 5 or 10 years from now, but at least as of now. But with some of your other disorders of sexual differentiation where it isn't as clear, they do advocate for waiting if the family is on board with that. Answers your question.
Thank you, Dr. Knight.
Yep, no problem.